I was very happy to welcome and to call to the podium Professor Donders. Professor Donders, welcome in Athens and to our maternity hospital. It is our honor for us to speak and to give a lecture about the vulvovaginitis cases, presentation and discussion. Professor Donders is Professor of Obs and Gynae in the University of Antwerp in Belgium, the President of ISIDOG, International Society of Infectious Diseases in Obstetrics and Gynecology. Welcome.
Thank you, Mr. Chairman. Dear all, I apologize not to speak any Greek, but I'm not a native English speaker myself, so my English will be very simple. And so therefore I apologize to speak in English for you today. I thank the organizers to have me today. I'm very proud to be here. I was in Athens a few weeks ago at your conference where I could talk about the same subject. And in October we will be back in Athens with our ISIDOG International Conference, and I all invite you to be there. So this is really nice. So I learned, I didn't understand much of what was going on, but I saw my name passing by from time to time. So I learned that you had a lot of information today, you had a lot of lectures today, so you worked hard, you must be very tired. So I think now it's time to have some fun, right? And therefore I would like to give you some clinical cases, and you would wonder why you would talk about clinical cases, because everybody thinks we know all this, you know, Candida, Gardnerella, I mean, nothing new. We all are acquainted with this. We are all professors in this field, and we exactly know how to handle our patients. But if we look in the textbook cases of how things are in the vagina, nothing is what it looks like. There are more exceptions than the rules. I mean, it's not all textbook cases we see. And textbooks, therefore, are boring. Another reason to talk about cases is that there's a lot of diagnostic and treatment failures. I mean, we must be honest. Some of these patients, they show up over and over again, and then, you know, we come in the morning, had some coffee, and then go in the office, and then you see, oh my God, she's there again. The same lady with the suffering of the vulvovaginal problems, and she's there again. So she has been seeing many doctors already, not just you. Don't think she just went to you. She saw 3 or 4 other ones, and she went to Dr. Google and saw it on the internet, and she went to the pharmacist, and the pharmacist, they gave her lots of drugs to try, and she went to the orthomolecular doctors, and they do expensive blood tests of 40,000 euros and so on. So it leads to hypochondria, which is really a huge disease that we have nowadays. And then they say, doctor, you are my last hope. Last week, I must confess you, I saw my patient who came the farthest distance ever to see me. You know where she came from? And she didn't come to visit Belgium. She came to visit me and flew back the next day. She came from Phuket in Thailand. Not to tell you that I'm a famous doctor or anything, just to tell you that people are desperate all over the world. They are desperate, they suffer. Today again in the plane I saw a mail of a lady from UK, and she wants to see us, to have advice, because it's the burden of this disease is really underestimated. It's more than you think. There's a lot of women that suffer and keep on suffering. They don't find help. So there is an interesting case to be discussed. So I have a number of cases, and I was asked to speak for half an hour. We already went over time in the symposium, so I will stop, or you will stop me if I go over time. I give you the other cases another day. It is not necessary that we discuss all of them, but a few of them, we can see how far we can go. So let's start with case number 1. And I want you to think with me, and you can interrupt me, you can shout, you can, raise your hands, do whatever you like. You can speak any language. I understand most of them except Greek. So if you try German, English, French, Spanish, and Italian, that would go fine, but Greek I can't speak. So she's 45 years of age. She has 2 kids. She has a copper IUD. She complains of intermittent pelvic pain. She has dysmenorrhea. She has this yellowish vaginal discharge. There is no itching. She has a steady single partner that still does exist, without complaints. And she complains of deep dyspareunia in her body. So deep in her pelvis, she says it hurts. It's not coming in, but it's when it proceeds. So what do we think of? I put a speculum in the vagina, and this is what I see. Anyone can help me? So what question did I ask? I asked, did you have an hysterectomy? She said, yes. So I look in the vaginal top, and this is what I see. Okay? What do? I use my microscope. I use my microscope all the time. This is what I see. You like this or you don't like this? If I see this, I don't like this, because there is no lactose. It's full of cocci. There is normal epithelial cells. They're nicely superficial. But here there's lots of inflammation. These are all leukocytes around these epithelial sites. So she has something that's inflamed. There is an inflammation there. I asked her, what did they do this hysterectomy for? And she says, I don't know the name of the disease, but it has something to do with blood in my belly. And it hurted all the time. And so I thought maybe you have endometriosis. So I took a biopsy, and she had in the cuff of her vagina a recurrence of endometriosis. So what is the lesson number 1 to take? Well, not all vaginal diseases are infections, right? But fortunately for us, most of them are. So case number 2. The same woman, she has this pelvic pain, dyspareunia, she has a discharge, no itching, the same partner, and pain. Very similar story. And this is what you see in the vagina. This is the cervix. This is the anterior fornix. And there you see red dots which look like small ulcerations. It's very much inflamed. And here below, you can't see it with the light on, but there is some yellowish discharge. I look in the microscope, this is what I see. If I tell you this woman is 45 years of age and she has no menopausal symptoms, she's not supposed to have cells like this, isn't it? This is a parabasal cell with a big nucleus, dark cytoplasm around its cell. It's not a very nice cell. That's an intermediate cell. Here there may be a superficial cell underneath, but there's lots of inflammation, no lactose, lots of bacteria there that are cocci. These are not anaerobic bacteria, these are aerobic bacteria. So what does she have? And you had a full speech about this condition because she has AV, which is aerobic vaginitis. And I'm glad that I could, in these days, define this condition as something different from Gardnerella vaginalis infection, or let's call it bacterial vaginosis, which is BV. Why? Because, as your colleague already told you today, that I understood, that lots of these women, they have an abnormal dysbiosis in the vagina and they get metronidazole. And they're not getting any better. So they must have something else. And that condition has now a name. It's called AV. And you took already a lot of work out of my hands, so I don't need to explain to you again how you can diagnose this. But I tell you one thing, it doesn't take long. You don't need to be clever even. It's very simple to do. You look in your microscope while the people dress their, put their pants on. you do the microscopy, and what you see is you look at the lactobacillus, you look at the number of leukocytes, you look how they look like. It was nicely shown how toxic they can be. You look how many parabasal cells are there, and you look whether there is small bacilli or cocci instead of the normal lactobacillus. And that you give a score from 1 to 2. And having done this, you will get this composite score of AV, which can be then light, moderate, or severely abnormal. Severely abnormal is a score of 6 or more, and that is a very severe disease, how I showed it to you. So this is how it looks like. Most of them are normal. Some have light IV, which is also quite normal. And then it starts to be moderate and severe IV. And severe AV is exactly the same as the DIV that we know from the dermatologists. So it's the desquamative inflammatory vaginitis. So this is how it looks like. And this is what we learn from this. Use all your senses. I mean, listen to your women. They tell you very often in which direction it has to be looked at. Solve the problem yourself. The lab will not help you. It doesn't matter if they culture E. coli for you, because E. coli is not enough to diagnose AV. You need your microscope to look at them. You need to see how disturbed is this flora. And I was a little bit afraid of the former lecture that you were pushed into the direction of giving too much antibiotics for this condition. Please don't do that. It's not because the lab will give you group B strep. It's not the lab gives you E. coli. You need to give antibiotics for this. The main treatment for AV is not antibiotics. You can give it for a short while, but not for too long, because it will make your people sick and they will end up with a nasty candida in the end. So antibiotics are not the full answer. So it is more frequent than you may think. If you look in your patients, you encounter this quite often, and it is present in all parts of the world. So let's go to the next case. 28 years of age. She's a nullop. She takes a pill since 8 years. She has an increased clear discharge. It's not yellow. She says there is a burning sensation, stinging, burning sensation. Intercourse is sensitive, but it's not impossible. But always afterwards, I feel a severe burning. It lasts like a few hours after that, and it's not nice. I need to go to the shower and then rinse myself because it doesn't feel well. You know these stories. You have these patients as well, I'm sure. There is no itch, there is no smell. Sometimes women don't smell, but we smell. But in this case, neither she nor me smelled anything, so there was no itch, no smell. She had a normal partner without complaints, and she tried. That is what always happens, you know. You don't know what people have, but you give them medication anyway, because otherwise they may think you're a bad doctor. That's not what you should do. I mean, if you don't know, tell them, I don't know. And I send you to someone else. Or we do more testing, or I don't know. But don't give them antibiotics because you don't know. Don't give them antimycotics if you don't know. It's not good practice. And it happens all too often. Also, this woman, she received fluconazole, she received miconazole, clindamycin, doxycycline by several eminent specialists. But none of this was successful. Yes. So we did a clinical exam. We looked at the vulva and perineum. We saw essentially nothing. But the vagina was slightly reddish, but they were normal rugae, so it was a normal anatomy of the vagina. There was indeed a somewhat increased watery discharge in the posterior fornix, but no smell again. And on the exam, it provoked some burning, but otherwise, nothing was painful and everything looked normal. So what would you do next? Tell me. Patient is sitting there. What to do? What would you do? Yes. Use your microscope. Exactly. exactly. In most of the questions I ask, that will be the answer. So I used my microscope, and I, before even thinking of the lab, I knew exactly what she had. So what does she have? Guess, what does she have? How do you call this condition? Who knows? No? Good guess, but it's not trichomonas. Why? Because she's full of lactose. There is so many lactose. Hardly any symptomatic trichomonasis will be together with lactose. They hate each other. They don't like each other. But what do we see? What are these? You would say maybe they are leukocytes, right? But they're not leukocytes. So what are these? These, ladies and gentlemen, are the nuclei of disrupted cells. So these are the very nasty, healthy, overactive crispatus lactobacillus. So the lactobacillus crispatus, who is a very strong type, and there is genetic subtypes that produce a lot of lactic acid, but a lot. They're very, very active. They produce a lot of peroxide, but they have peroxidase on board. They produce a lot of peroxide, and they produce a lot of lactic acid. So they acidify the vagina tremendously. So if you measure on these women the pH, it will tell you 3.6, 3.5, the most yellow strip you can find. It's extremely acid. And what happens with the acidity is that the epithelial cells can't stand it. So they explode, they burst. And this, ladies and gentlemen, acidity causes this burning sensation, and the condition has a name. It is cytolytic vaginosis. Now, this is very important and interesting. Why? Because we are all used to put a swab in the vagina and send it to the lab and wait for the result to come. And in this case, ladies and gentlemen, you will not find anything. They will always tell you it's normal. It's normal commensal flora. Maybe sometimes they find the group B streptococcus. So what? Nothing wrong with this. So this lady will not have a helpful lab result. You need to look in your microscope, or at least do a pH on this woman. For me, a pH test is much more valuable, much more useful if it is too low than it is too high. Because if it is too high, you still don't know what she has. She can have cervicitis, she can have trichomoniasis, she can have AV, she can have BV, she can have both. But if the pH is low, lower than 3.8, for instance 3.6, then you have to think of the possibility of cytolytic vaginosis. So what you do with these women, because otherwise you are going to ask me that question anyway, I heard it someone saying earlier on today, you use baking soda for them. So you rinse the vagina with baking soda in a solution, and that makes them much better. So they feel much better. I use it every day in the first week, and I tell them to taper down and say, okay, now you use it less often, 3 times a week, 2 times a week, as necessary. And they're very happy. Very importantly, to listen to your patients, because these patients they do not have itching, they have burning. And burning and itching are 2 completely different symptoms. We should recognize that. So what did we learn? We learned vaginosis is not vaginitis, because that's why it's called vaginosis. It's not a inflammation. Listen to your patients. Burning is not the same as itching. Burning is an enigmatic symptom. It's very difficult to place burning. Burning, if I hear they say it's burning, it's always, I know it will be a difficult consultation. It's not easy. It's not easy. Research is needed for that. Buy a microscope. It will help you. It will really help you. And I already promised you, Mr. Chairman, I promised you that we will come and teach you microscopy, because it will be the best thing in your life that can happen in your practice. Use it. So reassurance in this case, if you tell these women, listen, what you have is normal, it's just a bit too normal. It's too good. You know, It's like your stomach. You need acid to digest your food in your stomach, but if you have too much of it, you get an ulcer. So in the vagina, it's good to have them, but if it's too much of it, it starts burning. If you tell them that, they already feel relaxed because they think her husband brought her a sexual nasty disease and now she is suffering with this and so on and so on. That's what they always think. Can I take some water? Thank you. 32 years of age, she has a Mirena. I think you call this also Mirena here, right? The levonorgestrel intrauterine device. She had increased discharge. Her husband says nothing. Thank you. But her boyfriend, he says, she smells like anchovies. So he doesn't want to perform cunnilingus anymore. So there we are. Big problem, isn't it? She got doxycycline from her GP, but it didn't help. She tries to avoid sex. Who can blame her? And she feels ashamed and loses self-esteem. Big burden. My resident sees the patient. He does perform a speculum examination. He follows the local guidelines, and he decides to do a whiff test. You know the difference between a sniff test and a whiff test? You know? There is a difference, huh? Sniff test is what happens if you pull out a speculum and you go back because of the smell. That's a sniff test. A whiff test is if you have a common cold and you're not so sure about the smell, you put some potassium on the smear, and then finally you get the perfume of BV. So that's the difference between the sniff and the whiff test. So this resident wanted to be sure, and he did the whiff test. He put some potassium hydroxide on the slide, and he found a pH of 5.6. So he says, I have sympathy with the boyfriend. And I agree with the boyfriend. So he says, he comes to show me, and he says, I propose this lady to take metronidazole, Flagyl, for all 3 people involved. Well, what was my advice, you think? Well, you know the answer. Show me. Show me. Bring me a slide. Let's look in the microscope. I held a microscope with a camera on top and a screen so we can look together. It's nice. So you can show and point with your finger. So you use a 40 times magnification microscope with 10 times oculum. So you have 400 times microscopy. And it says there, it's not light enough, but it says phaco here, phaco. You know what it means, phaco? Phaco? What type? Which type? Phase contrast. That's the answer. So it's phase contrast. Is that complex? No. No. I never change it. I never touch it. It's just a little slide between your light source and your lens that breaks the light. And you need a very strong lens that can capture the light anyway. And because of the sideways catch of the light on the smear, it gives you much more contrast. That's what it is. It's nothing complicated. You don't need to pay millions of euros for that. So you use that microscope, and then he showed me, and this is what we got. So we have an increased watery discharge. We have a pH of 5.6. The sniff and the whiff test were positive and confirmed by the boyfriend, right? And we see now the clue cells also. Here's the clue cells. So this is the epithelial cell. There is the anaerobes that cluster. There is the anaerobes as well. So all 4 of the Amsel criteria are positive. So she has BV. Did I agree? Not yet quite. Why not? Because I looked more in my microscope, and what did I see? Fungi. I see these nice chaps, and the last speaker was addressing them. This is a non-albicans candida, for God's sake. So, If I would agree with my resident and with the boyfriend and give them all metronidazole, what will happen, do you think? They will come back to my office and they say, you are a bad doctor. I had a little smell, but now I have a bad itch. And I don't like that. A bad itch is much worse than a bad smell. So microscopy, ladies and gentlemen, helps you to find combined diagnosis, to find double things. It's not always one thing people have. Doctors always think in one direction. If a lady came to your office and she had in 1984 once Candida albicans vaginitis, then there is a stamp on her head. If she suffers in her vagina, we have to prescribe antifungal drugs. And that's not correct. You have to look because they may have different things. They may have combined diagnosis. So if with BV you fail to see Candida together with them, then they will come back with more symptoms than they had before. And that's not nice. And you can prevent this by seeing this. Having said this, if you look in the leaflet of metronidazole, Flagyl, it says Candida is a side effect of Flagyl. I mean, how stupid is this? How could Candida be a side effect of a drug? The reason is that it was there, for God's sake. It was there in the beginning, so you didn't see it. So therefore, my plea would be to go and see if there is not a double infection. So the Candida, ladies and gentlemen, very often, I don't know in Greece, but in Belgium, the young residents, they get a visit from the company and they give them a diagram and they say, you have to measure the pH, and if the pH is high, it will be BV, and if the pH is low, it will be Candida. None of this. I mean, look at this lady. She had a pH of 5.6 and she still had Candida. So if you see Candida, here you see Candida. Let me go back. Here you see Candida. I call that in Belgium we have this beautiful white asperges. I call this asperges sign. So it's a pseudohyphae. There is the spora that starts to have the outgrowth. This is a pseudohyphae. This is blastospores. So you see here a few lactose, so it's a grade 2B. There is much more other bacteria than lactose. So it's together with Candida. Here you see normal bacteria, normal lactose. It's a grade 1 with a nice hyphae. So it's a normal flora. Here you see full-blown BV with a full-blown Candida albicans together. So you can have all of these subtypes together, Candida that can go together with lactose, with aerobic vaginitis, with anaerobic BV, and with all subtypes in between. So Candida finds its way everywhere. It's not linked to pH, it's not linked to lactose, it's not linked to nothing. It doesn't care at all. Mr. Chairman, how are we doing for time?
You don't have any.
Okay. Let me. No, it's fine. No, it's fine. I'm halfway, so I keep the other half for later. But let me, can you show me the last 3 slides, please? Just to finish my. So this is ISIDOG. It's the International Society for Infectious Diseases in Obstetrics and Gynecology. That's our logo. It's very beautiful. We founded this again in Riga in 2015. This is the website. We're making a brand new website and we really want you to join. It's very cheap to be there and we talk a lot about vaginitis. We have Jack Sobel as a member, we have Steve Witkin as a member, we have all the European eminent people there. And we will come to Athens from 19 to 22 October this year and we would really like to welcome you. Because this is what I made as a first save the date, so please come and see and let's discuss more of these things. Thank you.
Very much, Professor Donders. I appreciate the sort of the time you give your lecture. That was very vivid and very comprehensive. Shall we see if there are some questions from the audience or to close the session? Υπάρχει καμιά ερώτηση από το ακροατήριο? ή να κλείσουμε τη συνεδρία. Mr. Motakis. Dr.
Congratulations for your excellent talk. Okay, number one priority is microscopy at the office, okay. But is there any place for cultures or molecular examinations?
Yes. Well, I'm glad for that question. And as myself, you also are involved in research a lot and in publications. And nowadays, if you try to publish a paper with good stuff, but based on microscopy, I mean, you're kind of old-fashioned. People don't like this. So also myself, we engaged in molecular biology more and more. So we did some studies on molecular biology for AV. And so we could find that there is much more than just bacteria that are wrong. It has something to do with the estrogen receptor, probably. So it helps you to explain a lot of things. And we discussed recently one of my PhDs graduated on molecular biology of the vaginal flora just 2 weeks ago. So we had Jack Ravel from Baltimore as a opponent. So we had long discussions about this. And I asked the question as a promoter. I said, listen, what do you think the molecular biology will bring us in the clinic? That's your question, right? What can we do if we have a patient and we have all this knowledge of molecular biology? Nowadays, not much. First, it takes too long. Second, you don't know what you're looking for because you get millions of answers, but no real answer for your patient. Third, you don't know what antibiotics or drugs to give because you don't know these bacteria, what they are and what to do with them. And fourth, the molecular biology is designed for helping us to explain things, to understand what's going on. But it's not designed to be a diagnostic. So except for simple things like a GBS test, in pregnancy, if you have a delivery in the labor ward and you could know exactly right now if she has group B strep or not, that would be very nice to have, this type of test. But to do the whole microbiome on a woman to help you to solve her problem, for now, I don't think it is any place.
Thank you very much indeed.